There we go. So welcome everybody to the third annual virtual diabetes symposium. So this is day one. We do have day two tomorrow evening as well. It is hosted, of course, by the Delaware Diabetes Coalition. Sarah Bloom is our executive director, and I'm Kimmy Moore, the current president, and you can see both of our contact information below. Oh, of course, I didn't check that my slides would move forward. There we go. Oh, now we're rolling through them. So just a brief background on who we are. The Delaware Diabetes Coalition is a statewide nonprofit organization comprised of a network of healthcare organizations working together to improve the lives of all people in Delaware affected by diabetes through awareness, prevention, identification, dissemination of services, and advocacy. So I do want to remind everybody on the call about our college scholarship. So the Delaware Diabetes Coalition established a scholarship to provide financial assistance to high school seniors who are planning to attend further education in an accredited higher education program or students currently enrolled in an undergraduate program who have type 1 or type 2 diabetes. So to be eligible, you do have to be a Delaware resident. I already explained school status. You need to have a GPA of 3 or better and would require a transcript. We do ask for a 500-word essay entitled How Diabetes Has Impacted My Life Choices, 2 letters of support from non-family members, and they need to be able to make an appearance or submit a video to be played at the annual Diabetes Wellness Expo. And you can only win this award one time. It is an $1,000 scholarship, and the deadline is April 30th, 2023. Email submissions can be sent to directors at DE Diabetes Coalition. Sarah. So you can get continuing education credits for attending this evening. To get those, you do have to watch the 120-minute webinar live. And then we're going to send out an evaluation to be completed by February 28th. This is approved for 2 contact hours through the American Nurses Credentialing Center, Commission on Dietetics Registration, as well as the Certification Board of Diabetes Care and Education. And our speaker and planner disclosures are on the DDC website. So before the end of this evening, we hope that you will be able to report an increased knowledge on the physical aspects of youth and diabetes, how to advocate for 504 accommodations for students, and current diabetes technology to better support and care for children and teens with diabetes in a school setting. So with that, I'm going to stop sharing and have Dr. Saylor share her screen, and then I'm going to give her an introduction. And are you able to share?
It's always these lovely technology things. Host disabled. I'll try one more time, Kimmy. So I think if you click on.
I'm going to hit advanced sharing options. There we go. Okay. I have that open. Who can share? You should be able to now.
Fabulous. I think you guys might see my crazy desktop for a second.
No worry. I'm going to let you get that straightened, and I'm going to read your introduction while you're getting all set. Well, great. You got set, but I'll still read your introduction. So Dr. Jennifer Saylor earned her PhD at the University of Maryland in Baltimore, Maryland. Her program of research focuses on physical and psychosocial aspects of transitioning to college for students with type 1 diabetes. She works collaboratively with the College Diabetes Network as the research liaison and member of their Campus Advisory Council Committee and Clinical Scientific Committee. She is currently the Associate Dean for Faculty and Student Affairs and tenured Associate Professor in the School of Nursing. She has presented and published in a variety of journals and completed funded research focusing on type 1 diabetes among the college students. She is widely published, a journal reviewer for multiple journals, including Nursing Research, AADE in Practice, and Diabetes Educator. The combination of Dr. Saylor's clinical practice, scholarship, diabetes camp directorship, and involvement in the College Diabetes Network illustrates a strong commitment to diabetes research, policy, and campus life for college students with diabetes. So with that, Dr. Saylor, take it away.
Wow. So tell me what you guys can see. Kimmy, if you don't mind, you see my notes, which I don't usually use, or do you see the slide?
Yep, I can see the slide.
Fabulous. So welcome, everybody. I can tell you, when I was preparing for this symposium, I was thinking to myself, I really want to know what it's like. As you heard from my bio, I'm so ingrained in type 1 diabetes, so much that people ask me, do you have type 1 diabetes? And I don't. But I'm very passionate about it. And it's a whole different type of chronic condition than unlike any other that I know. So I thought to myself, we've been through the pandemic. I wonder what it's like to have type 1 diabetes. And I was doing a presentation during the pandemic. So I asked my dear friend, and she said, as isolated as we feel, living this new normal, we can almost compare our abrupt changing lives during COVID crisis to that of being diagnosed with type 1 diabetes. And I thought to myself, okay, I've done lots of qualitative research. I've been studying this for years, but again, I don't live it. Everybody on the call here has been helping families with this. So she said, I said, tell me more. She said, it is unprecedented. It is relentless. It is unbelievably isolating, mentally invisible. So think about the time during COVID, and we're all still here virtual. A young teen or young adult can barely get out of bed on any given day without looking at some type of device, right? Something's beeping at them. They're looking at this device. They have to actually think about every single time. I can't even get out of bed. I have to prick my finger. I have to remember to take my insulin. I need to have so many grams of carbohydrates, but then I need to adjust for that. And then the list goes on and on and on and on and on. I didn't even talk about doing their hair, putting on makeup, anything. That was just their diabetes. And I thought to myself, oh my God. So it is constant. Everything is constant having T1D. So she said to me, exercise, friends, school, all of that, you still have your T1D with it. Now, we're all very intelligent here, right? The human brain doesn't even develop till age 26. Think about what we ask our young adults to do. Think about what our kindergartners are doing. I have a diabetes camp. I have 5-year-olds that are calculating carbohydrates quicker than any college student that I have. It's kind of comical, but we're asking them to develop much, much faster, making their own decisions about dosing medications. It's ongoing. The transitions are inevitable. And I'm really here to talk about those transitions. And a 20-minute doctor visit 3 to 4 times a year, no offense to healthcare, I am a nurse through and through, it doesn't cut it. We need constant. So I just want to say this presentation really focuses on going beyond clinical practice. I'm also not going to talk about numbers. I am tired by the end of the night. I was talking to Sharon, who's also going to speak. It's been a long day for everybody. Just full disclosure, I do not have any financial relationships to this, and I have no conflicts of interest. You can read the objectives that are there, but I'm really going to focus on understanding the challenges experienced by parents during the transition, because as you know, as pediatric nurses, as school nurses, and even as an adult practitioner, it's not just about the patient. You care for the entire family, okay, when you're dealing with a chronic condition. And then I want to focus on, besides the parents, kind of understanding all those challenges that come with experiences. I'm going to present some qualitative data from 4 studies focusing on this transition from the emerging young adult, from the parent perspective and also the adult perspective. So stay with me. I promise I might get a little teary-eyed. I'm very, very passionate about the work that I do, especially my qualitative work. So transitions are a normal part of life, right? We transitioned even during COVID, and there's not any data on COVID in these slides, I promise, but it is a normal part of life. You can classify it as developmental. It could be situational. We have health transitions. There's organizational transitions. These transitions, they can vary in length. They can be whatever we want them to be or imposed on us. But I will tell you, those with type 1 diabetes, it's so much more complex. And I hope at the end of my presentation, you're like, wow, I had no idea. When we talk about transition, the first thing that comes to mind is pediatric to adult care, which you can see in this slide is at the center. I'm really not focusing on that much. I know there's other clinicians that'll be talking about that. There's so much more to transition that we haven't thought about. These monumental transitions in young adulthood. Young adulthood has been defined by Arnett, and he had said it's 18 to 29, and you go through more transitions between 18 and 29 than your entire life. Fascinating. So think about this. So I want to take a journey with you guys, right? And we're going to take a few years of college life and really kind of see what it's like. We're going to go through a couple different studies. And when I say studies, don't fall asleep. It's really, I promise, it's words, it's passionate examples from people with T1D, but all of them are between 18 and 26. And I just want to talk about them. So I have a parental, relationship, college, and employment. At the end, I'll talk a little bit about pediatric and adult care. So I want to begin with the parent perspective. And this is kind of a fun little presentation that I love to talk about. I had a PhD student and she wanted to study basically, originally it's kind of interesting. She wanted to study seat time. And I was like, what is even seat time? Because I wasn't a pediatric nurse. And she really wanted to study about, children that lose school time. So we started talking and I said, well, I studied type 1 diabetes. And it was interesting because what I had found, she started studying type 1 diabetes, and from the parent perspective, what I would see in my research from the young adult perspective, I'll just use continuous glucose monitoring as an example. My young adults see that as a barrier to care because mom or dad are hovering. Where she saw it in her research as a facilitator. So we used to go back and back. I miss her a lot, but I just want to begin with the parent perspective. This is published in the Nurse Educator. And I can tell you the transition to independence is really, really hard for parents, especially when their kids are diagnosed at a younger age. It becomes part of them. It becomes part of their identity. And a lot of what we heard through this study was let it go. And how do I let it go? It didn't become a theme, but it actually was threaded through everything. So as I talk about these three major themes and some associated sub-themes, I want you to think about letting go. Think about even in your own school district, letting go of that maybe fifth grader to middle school or your high school to college. You spend a lot of time with them, especially those with chronic conditions. So theme number one was acknowledging parental T1D concerns. We had to acknowledge that. Two sub-themes came about was their safety at college. They're going to make mistakes. I understand they're going to do this. I can't tell you, well, I have heard people have called 911 because they just wanted to make sure their child was okay, but they were just sleeping soundly. So just being able to let go. So acknowledging those concerns. The most passionate actually came from a father that said, my concern was keeping her alive. So one of the other things that came about was navigating changes in the parental role. So you as the parent, so if anybody has children that have gone off to college, you go through this whole identity thing with or without a chronic condition. It's much more elevated when you have a chronic condition, especially one like T1D, because it can be life and death. So they're really concerned about their safety at college, but navigating that parent role. When you're a parent, you identify with that role, but what happens when they go away? What happens if it's your only child, right? So very, very hard. Parents express concerns about the potential for burnout. So they have this parent role, right? When the kids come back home or the young adults come back home, just know that they want to give them a break. So they end up taking care of all their diabetes needs. And I struggle with that, right? So what happens when they go back to college? Who's going to do that? That was one of the other themes that came about. Identifying support. And I'm not talking about support for the young adult with diabetes. I'm talking about the parent. The parent needs a support group. The parent said it almost, one of the people, which is not in here, they felt like something was severed, like their arm was gone. But they expected support from their diabetes care providers, which they did not get. As you transition from young adult to adult, providers are really there for the young adult, not really there for the parent. But when you're diagnosed in middle school, you're there for the parent a lot. And that changes, and they don't know what to do with that. The other thing that they really want with support was wanting a connection of a responsible adult on campus. There's a lot of research out there on that. That's a lot to put on another 18-year-old who's their roommate, who they just met for the first time. So parents did report a total scan of levels of involvement with their young adults with type 1 diabetes management while they're away at college. I've heard from, I watch their blood sugars on CGM machines to they have to text me in the morning, or I'm there if they need me and I just order supplies. It's all over the place. But another dad had said, which is great because we got to have some dads in our study, you identify with that role of taking care of your type 1 diabetic. And I never use that phrase. It's his words. It's hard to give up that role. That was the 3 themes, sorry. So transitioning to college. The third one, is identifying sources of support. I think I talked about that without actually having it up. I deeply apologize. College life. This is where I love to talk. So transitioning to college, this is the young adults. So go back, think about my friend's message. All that stuff she had to do before she got out of bed, right? I had a participant in one of my studies who was in California, and she was diagnosed 2 weeks before leaving across the country to go to college in New Hampshire. I can tell you, I did a big national study, and 71% said that they reported having difficulty managing their type 1 diabetes. Diet, irregular schedules, alcohol intake, all affects glycemic control. And you're all saying, yeah, I know that. Who cares? But how do we help them? How do we talk about how if you are really intoxicated, your glucagon's not going to work? How do we talk about having sexual relations with individuals and what that does to your blood sugar? Because healthcare providers are not talking about that. There are some of the conversations that I have with my students at the College Diabetes Network, which is the old name, the Diabetes Link, which is the new name. Social support, more specifically peer supports and peer networks, can increase a sense of belonging and can strengthen that academic and social development. And that's really where the Diabetes Link comes into play. And these are actually real pictures from students in my my network. So the type 1 diabetes link, this was formerly known as the College Diabetes Network. This is a nonprofit organization specific to students with type 1 diabetes. This is the go-to for peer support, resources, leadership opportunities. They have internships, and they want to be the ally that connects you to the people, the programs, and practical information that can help make your life easier at college. And we do have a very unique relationship with the School of Nursing to the Diabetes Link. So I am the faculty member for the School of Nursing, and our goal is really to improve college experience. I can tell you, I've done research there, and somebody will enter my study and nobody cringed. Their hemoglobin A1C in college could be like 12, very easily 12, 13, I know. And when they're in their study and I get them connected with the Diabetes Link, formerly known as the College Diabetes Network, their hemoglobin A1Cs are 8, 7, and they're super, super excited. But it's really not because of anything I did. It's because of that peer support that they had. So I want to talk about this study that was published in the Journal of Pediatric Nursing. So this study really looked at 4 themes, and type 1 diabetes affects all aspects of college living. Students are on a treadmill, right? And they're like popping gummy bears and people are looking at them. Well, because their blood sugar is low, but they're still trying to exercise. The college environment affects type 1 diabetes management. I very well know pediatric professors, and they'll say, well, you eat the same thing and you'll do this and you'll do this and you're not going to miss my class. And I think to myself, yeah, they are, because it doesn't matter if you eat the same thing and do the same thing every day, your blood sugar still might go low. So they need to have that grace, which is why they need accommodations at college. I can't tell you how many students are saying, I don't have a disability. I've had diabetes all my life. I do not need accommodations. Please, please, please get them accommodations. All the kids, young adults, college students will all take my class, because it's not just about them. It's about everybody. I'm like, is everybody good? Is everybody ready to take this exam? And they know, oh, I need a drink of water. And it might not be that they need a drink of water. It's that their blood sugar is low, or they need to run up and down the steps to control, maybe their ADHD or whatever else they have. And that's important to me, because you're asking them to take an exam. You need to actually give them all the tools that they need. One of the other things that came about in this is that type 1 diabetes facilitates growth and maturity. Oh, sorry, I went back. Sorry. And this came loud and clear, that they went to college a lot more mature, and strategies for using type 1 diabetes. And this is where I focus on, which is seeking and receiving support, accepting the diagnosis. There is a huge, huge increase of people being diagnosed in college. So I see it a lot. I've been around where I've helped people put on the pump for their first time or their second time, or, supplies were delivered to my office to make sure that it got there. Learning glucose control by trial and error. This was kind of funny, not funny, but interesting. This one guy was very cavalier about it. He just said, I decided that I wasn't sure how many carbs I was going to eat at the all-you-can-eat pasta bar, so he would not dose before, he would dose after. And then advocating for oneself was very, very important in this study. So that was the overall. Go into some detail. This was the first theme that we identified about it affecting all aspects of life. I'll let you go ahead and read that. But a lot of young adults, college choice, to be clear, like a lot of them will stay closer to home or even take a year off. So it really affects that. So as you're guiding, as school nurses, as you're guiding these students, really have them look at it. Is there a diabetes link chapter at their university? That could really help. T1D really complicates social aspects of college, making new friends. How do you include alcohol in all of these things? Sleep and college do not seem to go together. There's a lot of pressure to stay up late. You forget, sometimes you wake up in the middle of the night, you're low, and you're like trying to be quiet, is what one participant said. Your pump's beeping, your roommate's awake. And like I said earlier, it's a lot to ask another 18-year-old to be responsible for another person's life. College affects diabetes. I think I talked a little bit about this, but I just wanted to state that one student said he can't make it to the dining hall and get back to class in time. So again, I've pushed and pushed and pushed at the university that if somebody has type 1 diabetes, they should have preferential scheduling. They should get their classes scheduled first. So if you are at a school district where there's multiple buildings and things, just think about it. I taught 2 classes today. I had 10 minutes in between. I barely got from one place to the other. I cannot imagine doing it with a low blood sugar. Just to add, I had gestational diabetes, so I do know what it's like not to even be able to check my blood sugar when it was like 41, I think was the lowest I went. But college students have a hard time balancing T1D management with the dining hall as well. The third theme is it forced him to maturity. And I talked about that, but maturity occurs at different levels. It has to do with gender. It has to do with brain development. But being diagnosed with type 1 diabetes has either hastened or altered it. I can tell you, I've seen people thrive on that, but I've also seen them, it kind of stunted their growth maturity. Okay. Also, I can tell you participants looked at life very differently and felt responsible for others. Somebody's called it the carpe diem philosophy. As a young person said, being diagnosed taught me not to sweat the small stuff in life. And maybe that's something that we all can learn. The fourth theme in this one was that strategies for type 1 diabetes. And this was, I talked about the trial and error, which is kind of interesting. And this concept did emerge. And the more people know, the safer you are. And I think this is really difficult to put into practice, but there is resources in the diabetes link that can help you tell your professor or tell your roommate, and all types of resources. So I highly recommend looking at that. I just wanted to throw in some practical implications for practice. So education should support the developmental needs. And I know I'm really talking about the college aspect, which even if you're in kindergarten, you need to start preparing the parents for that. But having developmentally appropriate education. And this part is near and dear to my heart because the College Diabetes Network, Diabetes Link, there wasn't anything for young adults, nothing. You can't treat them as an adult, and they're not an adolescent anymore. They're in this weird space. There's been a significant number diagnosed during adulthood. And when I say adulthood, I mean 18 to 29. Okay. The other thing is the implications for healthcare providers. They really need to focus on teaching healthy, modifiable behaviors of sleep, physical activity, not the canned stuff, like really and truly just listen to them. And again, at 12-minute, I think 20-minute max is all you get. We really need to look beyond that. And I will also tell you the biggest thing that I've heard from every single participant, they're not a number. So don't ask them what their number is. Ask them how they're feeling. As a school nurse, don't ask, what was your blood sugar? Just ask them how they're feeling. They're not a number. They are not a T1D. They're an individual. So let's go beyond college. So emerging young adult is filled with all these transitions, but it also goes beyond college. Okay. But this also leads to this huge, unbelievably heightened psychological and emotional stress, unfortunately. And this is where I think, even if you don't have them in the school, just preparing the parents, I think would be really helpful. So what are these changes ahead? Well, they're moving out of their parents' house to go to college. They're moving out even after college. They're entering the workforce full-time. What does that look like? I've talked, and you'll hear one of my studies. It was interesting. I got to talk to somebody who works for a nonprofit, who's a lawyer, who worked for law enforcement, to being a teacher. They become financially independent. You'll hear about how hard it is to actually look through insurance policies. I'm sure some of you struggle. I still struggle with my parents. Independent decision-making on diabetes care. And I say that meaning sometimes your friends chime in, sometimes your significant other will chime in. I've heard stories of mother-in-laws saying things, so it becomes very interesting. And then increasing importance of those friendships and those romantic relationships. You're beyond college, you're now working. So what does things look like? So let's talk about it. Let's talk about transitioning to a relationship. And this can happen in college. This can happen in high school. So I want everybody stay awake. I'm not talking about numbers, right? So this is going to be a qualitative study, and we identified 4 themes. And this was about dating relationships among young adults with type 1 diabetes. And I will preface this with, I did this study with my colleague up at Brigham Young, who has a very different, social environment than we do here on the East Coast, but did really love them. So sensitivity, theme number 1. Participants expressed a hyper-awareness and sensitivity with regard to how they thought people without diabetes would perceive them. One participant, which was a female, said, "What are people going to think? Is anybody going to be interested in me? I have type 1. Is somebody going to be completely turned off?" And trust me, across the spectrum, they're thinking this, even in grade school, middle school, they got devices all over them. A lot of the participants in these focus groups, they focused on emotions living with type 1 diabetes related to relationships. And they used words which broke my heart: stigma, anxiety, mental diabetes. Mental diabetes? As one participant actually noted, it's not easy just taking insulin and counting your carbs. Sometimes the anxiety of other people knowing it is actually worse than doing all of that. So theme 2 talked about the physical appearance in type 1 diabetes visibility. So participants said that in a romantic relationship, they were self-aware of the added visible ability of type 1 diabetes created by the use of T1D technology. I don't want my partner to think I look gross, right? I have things glued to me. I have scars. That's really heavy to think about, right? It's a huge thing for me. I know it sounds superficial. To me, it's not superficial. Technology seemed to heighten concerns of all the participants in this study. They debated over the burden versus the benefit of technology. And I said in the beginning, do you remember? Parents and children debate over the burden and the benefit of CGM data. Who do you share it with? I have a whole nother thing I could talk for hours on this topic, but I promise I won't. But it's invisible. I'm putting this big clunky tube, on my hip. I have this, but it's 24/7. Everyone's going to see it. I can't tell you how many students I know in college that take everything off because they just want to be quote unquote normal for a day. And then they're, out having dinner and with their friends and things, but their blood sugar is out of control because if you ask any person's dream of type 1 diabetes, many of them that I have studied said, I just want to break. The third one is boundaries and independence. With a romantic partner, should you share your continuous glucose monitoring data? One participant, she described a time when her boyfriend called her roommate to wake her up because she was really, really, really low in a nocturnal hypoglycemic event, while other participants did not share their CGM data. So the quote here is, this individual is very, very defensive about it. As you can tell, it is totally something that has impacted me. So she does not share the CGM data. And I do know that this participant was a female. They also expressed a desire to remain independent in their diabetes care through support of the romantic partners was greatly appreciated, right? So they want to be independent. They want some support, but not too much. But where is that fine line? And that's very interesting, as you'll see in further studies, kind of where that falls. They wanted parents to trust. This is a really important word, trust that they were capable of managing their diabetes. We all have to trust that our kids are going to do the right thing when they leave us, right? You trust that the child that you're caring for in the nurse office in your school is going to do what they're supposed to do that you told them when they leave your office. So trust is a big thing. One of the participants stated, I think when you get older, you just realize how important that accountability is and how important that tough love is for parents and to take care of yourself. So this individual has come full circle. Again, we're talking about relationships. They're through college, but they've come full circle. The last theme is support from their partners. This could be a boyfriend, a girlfriend, but a desire for boundaries and independence in diabetes management. many participants in this particular study positively described partner support, especially a non-judgmental support. Do you remember I said they're not a number, right? Having a sense of security in an emergency. Many of the people that I talk to will take care of it by themselves, but they want them there as kind of a safety net. And you can read this quote, but first date after camp, phone beeped, connected to CGM. They had a juice box in their purse, and that meant a lot to this individual, and he was very grateful for that. However, though, if a potential romantic partners were unwilling to be supportive of T1D, I tell you, in this focus group, I can read this quote and just remember exactly the room scenario. It's a deal breaker, was the exact phrase. Another female participant said, if they make weird comments, they shut it down right away. I also will tell you, before I move on to employment, in my diabetes camp, I've had siblings in my camp, and some of the siblings didn't even understand what type 1 diabetes was. And some of the comments that they would make were not appropriate. So when you're in the school nurse role, it's really important to be hypersensitive to those things. And even not just with type 1 diabetes, but all chronic conditions. Like, this can be applied across. So now we're up to employment. I hope everybody is still awake, but this final study is about employment. So I kind of went through all the different transitions, and my diabetes camp has formed my program of research for this. So we did a thematic analysis like all the others and have found 4 themes: sharing diabetes with others, dealing with discrimination, keeping up appearances, and receiving and accepting support. So participants I had 2 focus groups actually up in Boston at the diabetes link, and they both expressed concerns about hesitancy to disclose their diabetes. I have students that don't tell me. They do now that they've, gotten to know me, but they don't tell their faculty. Some participants felt strongly about how to share it, right? So the first participant, you can see this is very, very different. Okay. The first one was like, I'm a little nervous about disclosing. I didn't mention it in my interview. I'm going to let it come up naturally if it does. The other one was very adamant. This is mine. It's my diagnosis. This isn't yours. You can't have it. And I'm sure as I'm reading this, you're thinking about kids that you've cared for. It's me. This is my demon. It's not for you. I will ask you if I need it, meaning I'm needing help. I appreciate the help, but that's why she's extremely protective. And I know this was a female participant. What she hears is, I'm just trying to help. And their help really isn't that helpful. Okay. Many other participants in this study reported that they did not formally share it. I think I talked about that a little bit. One says that they really don't tell them when they're on a job interview. They don't hide it. They just see, they'll see like something on their arm. During the pandemic, I said I wouldn't talk about the pandemic, but I went to a coffee shop and a little girl walked out, and she definitely had a CGM on her arm, and it was covered in army tape, and I had commented on it. And she was so excited that I had commented that I love the tape on her CGM. And I guess she was surprised I even knew what a CGM was. And I did feel bad because she asked me if I had one, and I didn't. But she was just so excited that I had even asked her. So the second theme that came about was dealing with discrimination. And everybody on the call, I'm sure we can, recall a time when you've witnessed some type of discrimination, but this one kind of broke my heart. It was echoed by over half the participants of feeling shamed, stigmatized, or judged by a high or low glucose number in the workplace. They expressed feelings of shame of having type 1 diabetes compared to having another condition like cancer. And specifically in one group of 8, there were 4 participants, so that's 50%, were perplexed by this feeling of shame. Coworkers seem to understand that type 1 diabetes is a serious illness, but participants said that other illnesses such as cancer got more empathy. And one worked at a coffee shop, and this is very sad, as we're all healthcare workers. One healthcare worker, many had said it's like diabetes in a cup, meaning that there was so much coffee in there or so much sugar in their latte. A lot of coworkers, I think they were being supportive, looked at her and basically just said, I'm just going to pick my battle today. But could you imagine just being attacked as you work every day? That's tough to swallow, especially, I mean, to me, she's a 20-year-old kid, you know? So third theme, keeping up with appearances. So there's a huge difference between college life and the workforce. And this blew me away. I did not expect this. I love the college environment, but I did not expect this whatsoever. Participants recognized the huge impact on the workplace community and wanting to manage their T1D accommodations. Let me explain. So if you miss a class, this person says in college, sucks for you, right? If you go into the workforce, and this individual was in law enforcement, it not only affects you, it affects everyone else around you. The anxiety and the stress that has on you is powerful, right? The other one says, and this, I think this individual might have been a lawyer. He had said, it's fine. I'm just going to shove a bunch of gummies in my mouth and I'm going to make it happen. And I'm not taking a break, because they don't want to appear different. They want to keep everything up. The last one has to do with troubleshooting diabetes related technology. And this is something that we need to change. But this diabetes coalition, if you can do one of many things, 9 to 5, you have a 9 to 5 job. Guess when the diabetes related technology offices are open? 9 to 5. It's great. You need stuff for your insulin pump. You need a new CGM. Something's happening. You're going to be on hold during work. So here you are. Think about it. You guys are caring for hundreds of kids. We need more school nurses. We absolutely do. You're caring for hundreds of kids, not even kids, them and their families and their friends, to help them all understand about type 1 diabetes. And you yourself have an individual with type 1 diabetes. You work 9 to 5. I know it's much longer. We all work longer. How are you going to call to get new supplies? You can't. They work 9 to 5. They reported communicating with diabetes supply companies and healthcare providers was particularly difficult. The nurse practitioners, do they work at midnight? Because I have people that get off at midnight. They need somebody to talk to. They can't take a 30-minute break to go do a telehealth call, waiting for you because you're with another patient. Totally understand, but it's not going to happen. So for the people that I care for at college, I told you, I've been on hold while people went to class. It could have been 50 minutes and still on hold. Anyway, sorry. So despite the differences between professions, and like I told you, there was law enforcement, anxiety with work, there was a lawyer, somebody that worked for a nonprofit organization was in this study as well. But despite all these differences, they recommended, so again, I'm sure you do this in the schools, but please tell them when they go to college, keep backup supplies in the workplace, extra insulin pumps, batteries. Believe it or not, not everybody has a battery when you need one for your CGM, food for hypoglycemia. And that was another big talk. People would eat their food and they would be like, how do you tell them, please don't eat my M&Ms or my Skittles? I need those. But that was one of the recommendations that, they had come up with. All right, final theme. Everybody stay with me. Receiving and accepting support. This is really hard. And depending on when you're diagnosed, depends on how you handle it. Okay. This is the double-edged sword is the best way to describe it. While support is essential, about 25, almost to 30%, we're scared to use them. Support from human resources. What is that? Available accommodations in college, totally different. You know what? Look, when they're in your school, they have a counselor. They have all these things, right? At work, there's not really accommodations. It's scary to ask for things. Oh my God, are they going to fire me? I have to take more breaks. But anyway, life does not pause for diabetes, as one said. Okay. So pretty powerful. So all of these studies that I talked about, can anybody through the chat feature, so I know that you're awake, tell me, what do you think is the number one thing that is in common with all of these studies? All of my ranting and discussing what's in common. And I do want to end soon because I know I want time for questions. You can type in the chat if anybody is still awake. But what was the common thing with all of these things? No answer is wrong.
I just gave everybody the ability to do that. So hopefully.
Oh, thank you.
Again, I didn't realize that was not able to happen. So you guys should be able to chat now.
No worries. I think I was a slide off when I was talking in the beginning. Isolation, yeah. Wow, these are awesome. Feeling different, feeling normal. These are amazing. Sorry, my chat feature's on my other screen.
I think it may only be coming to the hosts and panelists. So if any of them you want to highlight, you may have to read out loud.
Feeling of uncertainty. There's a couple people still awake. Extra work. These are amazing. I have to say, I think that you all have hit it like perfectly. How about one thing that could help all of these things? Okay. Let me see if I can get my screen to work. Is support. Support can help that stigma, communication, knowledge, all of these things. So I have a whole nother PowerPoint on support. I'm happy to talk to anybody after this. Looking at the individual, please, please, please look at them. They are a human with diabetes. Okay. Support's huge. Where do you look for support? I will tell you the number one place they're looking is their peers. Okay. So if we can help educate peers, that's the best thing. How do you find peers? Peers with and without type 1 diabetes. You need to create networks. I'm happy to come to schools to help create things. And, and it doesn't even have to be just T1D. It could be chronic conditions. There's so many invisible chronic conditions. Okay. Family. Family is an interesting topic. How do you define a family? Family can range from across the spectrum of, and I don't want to use the word, but interesting I'll use, to extremely overbearing and loving. Okay. Others with T1D is awesome. I know a lot of my college students celebrate their diabetes birthday. Some of them do it in my office. It's great. I have popcorn in my office, so they all show up. And then your healthcare team. And I do want to talk about the healthcare team because you have no idea the impact that you can have on these children. You have no idea. The school nurse is the one single thing that follows them. Yes, they have a pediatric endocrinologist, but I do population health and community health, and I take, my college students into the schools. And the number one thing is the school nurse, the school nurse, the school nurse. You are so powerful. I have just 2 slides real fast on transitioning, but remember their peers is where they're getting their information from. Okay. Transitioning. Look at these lovely pictures. That is a pediatric hospital. I will tell you the balloon picture is not a pediatric hospital. It's actually, there's a few rooms in an emergency department in Cleveland. And this picture's not from Cleveland, but I do know there is ones that are for young adults. And I think that's really important because the young adult population, I don't know if I said this earlier, but the young adult population between 18 and 29 has the highest hemoglobin A1C than any other age group there is. Okay. So you want to talk about where people are getting their care? Look at this. This is from college students. This is 473 students, I think from spring of 2020. I think spring of 2020. Little old data, but I can tell you we've studied this for 3 years in a row. The data is the same. Okay. 280 go to an adult diabetes clinic, diabetes care, right? So an adult, 280 out of, I think there was 473 in this one. You can see only 134 stayed at the pediatric clinic. Why? Did they end at 18? Did they hit 20? Because this is all college students, freshman to senior, right? Primary care physician, there's an adult transition clinic, which I think we need more of. I know the state of Delaware does have those. This I found interesting too. So this is what I focus on, and we as nurses can do this. Healthy eating. Look at the alcohol starts changing. I think that Kimmy talked about accommodations in the beginning. Please, 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 please have them get accommodations. Okay. They get accommodations for type 1 diabetes. I would push for preferential registering. I would push for a refrigerator. I would push for a dorm, if it's a nice dorm, close to the nurse. But parents don't know. They have no idea and they don't do it. They come to the university. I'm like, well, what are your accommodations for T1D? Because they find out it's my passion. Family planning. Look at sex and intimacy. Physicians typically in general are not, they're not okay talking about sex, whether you're on top, on the bottom, but that's what we do at the college level. So they won't talk about it. Okay, I'm ending. Change is coming. Okay, everybody's changing, but too much change is not a good thing. According to Michael Scott, you can ask the climate. Now, what do all students do when they're trying to go through this transition and we surveyed emotional support? What do? They just put on a brave face. And that is our lovely Michael Scott's brave face. So thank you, everybody. You've been wonderful. I will take questions and I'm happy to take stuff offline.
Okay, thank you so much, Dr. Saylor. That was a really informative talk, and you absolutely kept everyone awake. You kept saying that I was wide awake the whole time. So with that, if anybody else has any questions, I see some chats come in. I do have one question in there for Dr. Saylor. So this one popped up pretty early on, so it's probably in reference to some things you might have mentioned early. Should there be a change to the accommodations for a student with type 1 diabetes as they transition to college? So I think you just mentioned that, but I'll let you answer.
So should there be a change? And Kimmy, you can call me Jen, but is there a change?
Should there be a change to the accommodations?
Yes, and if you look, when it was the College Diabetes Network, there was a whole link of what those accommodations should be. And especially at the University of Delaware, they can absolutely reach out to me and I can help them with any accommodations. But yes, there are accommodations for type 1 diabetes, meaning they may come. These are some of the ones that I always have. Refrigerator in the room. A dorm, like I said, if it's nice, a dorm closer to student health. And you can really push for, which I always try and do, registration early with the athletes and the honor students, because athletes get first registration, which upsets me. Again, I know I have athletes, I get it. But people with type 1 diabetes I've had people late for class because they're going from one class to another, blood sugar is dropping, they're trying to get there because it's across campus. So again, early registration so that you can schedule at your classes because classes aren't filled. A refrigerator in your room, Close to that, I'm trying to think of the other one. Oh, your unexcused absences within reason. Because if your blood sugar's low, you can't take the exam. You can't. Like, it's like asking somebody who can't see without their glasses, oh, take this exam without your glasses, you'll be fine. It's not fair. So we need to do a lot more in the state with type 1 diabetes, a lot more. And it starts with all the school nurses. There's so many of you. You have the largest voice, and you can't take care of all the kids with T1D. We need more school nurses. We absolutely do. So, and anything I can do from the state level, I'm happy to. I am part of a bunch of different state initiatives. So anything I can do. No, your 501(c)(4) does not follow them to college. And you know what the hardest thing is? The the college student has to apply for it, not the parent. And this is one of the other things, if you guys take away, is the child, and I have a 20-year-old who's technically a sophomore. Okay. The child has to do all this. Like, as an associate dean, I can talk to the parents, but we don't really deal with too many parents. Like if I'm teaching, a general class, nothing follows through to college. You need to apply for them. And I will tell you, I have students with ADHD, you name it, all kinds of things, narcolepsy, keep going. It goes on and on and on. They don't have to use all their accommodations. So I have students that have ADHD, and they'll say to me, my class is in the morning, I'm totally fine. I don't need my time and a half. I don't need this. And I never know what they have. I guess, does anybody know what it says? I basically get no information. It basically says, Kimmy Moore has accommodations for time and a half, 3 excused absences. That's it. And I don't have to do anything with that paper. The student has to come to me. So I try and educate all my faculty, say, beginning of class, first day class, tell them, if you have accommodations, you need to come reach out to me, because it's not an automatic. And I think there was another question in the chat about accommodations. Their counselors, so high school seniors should be able to contact their counselors. Yes, absolutely. I will tell you, the high school counselors do an amazing job at pushing the student in the right direction. And I mean pushing. When they get to college, they don't always do it. I'm finding out it's spring semester. So I'm finding them coming to me going, I didn't do my accommodations. I was supposed to. My mom told me to. The high school counselor told me to. And I'm like, okay, now we need to do accommodations. It can take 8 weeks. Like, it can take a really long time to get accommodations. So I always say to students, and even my son, I'm always like, take the accommodations, fill out the paperwork. You don't have to use it. Nobody, and I promise you, nobody knows. So if anybody is on the call, like, I never know what they have. Ever. It just says, this is what they get, X, Y, Z. That's it. So I don't know what they could have. I don't know, blood, whatever. I mean, I have no idea what they have. Honestly, they could suffer from migraines to having leukemia, and the accommodations could be the same. So we never know. So please reach out. So other questions, because I could talk forever about T1D in college.
So we have about a minute left.
Sharon's like, I've had a long day.
Anything else in the Q&A or in the chat? Reminder, only we can see the chat. It's set up for hosts and panelists. We have about a minute if anybody else has any other questions. And Jennifer, it sounds like that you are open to, if there is any other questions that come, having them sent to you. And the group.
If parents want to reach out to me prior to them going into college, I'm happy to help, or accommodations. I always try and look for a university that has a diabetes link chapter there.
Wonderful. Well, thank you so much. And thank you for your time. If you'd like to stay on for our next speaker, Ms. Sharon Rose, we would love to have you on. And yeah, with that, Sharon, would you like to? Yeah, thank you. I always say you can't you can't hear all the applause when we're via webinar, but thank you so much.
I will definitely be here, Sharon. I'm going to go off mute and see my college student before he heads back.
Thank you. And Sharon, would you like to try to get your screen set up, and I will introduce you as you get ready.
Okay, so is it up?
I'm not seeing it yet.
All right, so help me. How do I
Let's see.
share?
So I'm double checking here that I didn't disable it. Yep, you should be able to share. So do you have the screen, the green share screen button at the bottom center of your Zoom, or possibly the top center?
Okay, let me take a look and see where that is.
If
My
you have any
Zoom.
issues, I can share the slides for you. It's always easier though if the presenter does, because then they can kind of move around as they please.
Yes, there we go. Doop, doop.
Great, and
Let me
I
go
will introduce
back.
you as you get that, as you finish getting set up. So having been a school nurse at Stanton Middle School for over 26 years, Sharon Rose has had the opportunity to work with and see the many challenges that have happened over the years with her students who have diabetes. She collaborated with JDRF to help educate and bring awareness to her school community by hosting an annual Kids Walk. In 2016, her granddaughter, who was 7 at the time, was diagnosed with type 1 diabetes. As Delaware's NASN director, she worked with other state directors to revise the National Association of School Nurses position statement on diabetes to include language addressing the complexities of health concerns and the importance of advocating for a safe environment, ensuring that students who have diabetes are successful in school. And with that, take it away. Oh, and we're currently seeing the dual slides. So we're still seeing your speakers names here.
Okay, on the other side, let me do this. Sorry.
You might be able to change display settings to change that.
Let's do this. Sorry. Let's stop sharing. Let me go back up here. I'm sorry.
Oh, no worries.
It's a long day. All right, so I can put this one up. Is that one working or no?
Perfect. Take it
Okay.
away.
Sheesh. Who said this was easy? Well, thank you. Thank you for inviting me. And I got to say, going after Dr. Saylor, you were just wonderful. And I appreciate all you do for our children. And I really, it resonated when I heard letting go, because as I work in a middle school, I get children that have come up from the elementary school, and I'm a big proponent of having them advocate for themselves. It's just so important. Here's my disclosure. I have nothing to disclose. Nothing. I'm boring. I don't have anything. I was asked to go and unpack the diabetic toolbox. NASN, the National Association of School Nurses, has worked very hard to give toolkits to other nurses. And in Delaware, we are very fortunate to have a school nurse in every public, charter, and the majority of private and parochial schools. So we are on the cutting edge. So a lot of things that we do is just for us like common sense, but the toolbox is used all across the nation for nurses who do not have that. They don't have a nurse in every school. So my objective is, the purpose is of this presentation is to provide the skills and resources to help school nurses develop individual care plans, emergency plans, and how to advocate for students with diabetes to be safe and successful in the school setting. And these are some of the things that I'm going to cover. The assessment of, these are some of the things that you can find into the toolbox, and if you're not sure, the assessment of a student who has diabetes, an individual healthcare plan, what it is, how to develop one, an emergency care plan, 504, what things to put in, a list of supplies that you should have in your office to keep our children safe. And then the toolbox also has model procedures associated with diabetes. If you're not sure how to do a finger stick, it will show you how to do a finger stick. If you're not sure how to navigate a CMG or the continuous glucose monitor, it will help you do that. If you're not sure how to do ketones, there's a module for that. There are sample plans that you can pull from and use. And I did leave the link here if somebody would so choose to want to go at it. So the whole purpose of this is to provide resources and forms and the background information. These are the how-to guidelines for things that you may be coming up with, like hyperglycemia, hypoglycemia. To Dr. Saylor's point, how to plan for extracurricular activities, how do they count for carbs, everything that our kids will need to be successful as they transition, like from middle school to high school to college to the workforce. So I have this in here, a 504 or an IEP. A lot of times I have children coming to me and their parents they really, really want an IEP. They think that they get more accommodations, they get more supports, they just think it's better. But it is a child has to qualify for an IEP. They are tested, and intellectually they have to qualify for the special ed. It also ends with the education. So, and it also focuses more, because it focuses more on the instructional accommodations and less on the activities of daily living. Where a 504 are things like in middle school, high school. 504s have accommodations that can continue going on, and it's a fluid document, and the children are able to have phones on their persons, especially during state testing, because that is a big thing. They are able to do a blood glucose before taking high state tests, and if need be, postpone that test if their blood sugar is too high or too low. They're able to have the water bottle in the classroom, and they don't have to be, there's no limit on how many times they can use the restroom. If we're having them drink the water, they're going to have to use the bathroom. They're able to have snacks in the classroom. A nurse or an adult may accompany students on all trips. And I have May up there because by the time they become 8th graders, they don't want me and they really don't want their parent. They want to have that independence and they want to be able to go by themselves. And this will follow the student into adulthood as long as, like Dr. Saylor said, they take the initiative after high school. They do it for college, and then they say, here are my accommodations for the workforce. But both of these, the 504 and the IEP, they provide the accommodations that a child needs to be successful with their peers in a regular classroom. So in this form, and this is a 504, and I tried to put the whole thing on and it just didn't work as well. But this is a 504 where it tells you what the child, like what the child needs, who is the part of the multidisciplinary team, which the child should also be included. Down there you see student. I am a firm believer that children if this pertains to them, and if we want buy-in from the child, if we want compliance from the child, they really need to be part of this team. They need to be part of the decision-making so that we're not telling them what to do. I get when they're younger, they may not have a whole lot of say, but starting in middle school, high school, onto college, especially in middle school and high school, if they are part of this team, if they are part of the decision-making process, then they are more apt to advocate for themselves when they get to college and into the workforce. Then again, here are some just of the accommodations. Food, can they leave class early so that they can go check their carbs, get the lunch that they have calculated for? Do they need snacks? Do they and then also for me in my building, I make sure that if there are snacks brought in, the teachers I need the carb counts, just so that if I do have a child, we don't have to play a guessing game. We don't have to say, well, it was a cupcake. Did it have what kind of icing? It really, I want it spelled out. I don't want them to say, no, I can't eat that because I have to cover. And then I don't also want to play the game of, did they give themselves too much? Did we overcalculate or undercalculate? Technology, do they have access to the Wi-Fi in the building? Can they have their phones? A lot of my children do use their phones as their where they read their CGMs from. And I do make it a point that when it comes to the all the high stake state testing, that my children can have phones with them. There are some in the elementary schools, there are some nurses that will have, actually all schools can have it, but have an iPad that will hook up and connect with the child's CGM so that the nurse can see those readings as well. Absences, they can't be penalized if they miss a class or if they've been in the nurse's office because their blood sugars are too high or too low. And that includes if they miss school altogether. Again, extended time. Do they need the time? Sometimes my children don't need the time. Sometimes they utilize it. I believe having trained staff in the building. What are the signs of hypoglycemia? What do you do? Who do you call? Please call. I always tell my faculty, please call me first. Also, when you do suspect a child of having hypoglycemia, can you send them down to me or call me to come get them? Or do you send them with a child? Or and then the UAP is unlicensed adult, unlicensed assisted person. Also, you want to know, oops, sorry. You also want the bus drivers, the cafeteria, the folks, even the custodians. You really want somebody there on the later in the day when a lot of the folks are gone, because if you're having the practices and the custodian might be the first person to come across a child that is having a hypoglycemic episode. And then again, activities. All children are able to go to all activities. Therefore, do I need to stay? In the beginning of the school year, I stay after school for all practices, games, whatever the child wants to be participating in, until I have an understanding, like they understand what they're doing, they understand, like they are stable. I will, then I might go home like a half hour before them, but I will stay because they deserve to have somebody there and they deserve to be able to participate in all activities. I also believe communicating with parents is essential. If the parent, I have found that if the parent trusts me because I'm communicating, I'm having a conversation, I'm asking them questions, then if they trust me, then their child is more apt to trust me as well. If the parent doesn't trust me, then the child is not going to trust me either. And that is very important. We really need to have open lines of communicating with parents and guardians and the teachers. Again, there's the water and bathroom pass. And then the disaster management, I will touch on in a little bit, but this is where, you know, what happens if you have to shut your building down for, I don't know, if there's, God forbid, there's a fire, there's whatever. It's what do you have in place? And who's, you know, and there again, you want the more people in the building to be trained so that if there is a disaster in your building, the child is safe as well. You know, like where are the emergency supplies located and who is going to scoop up and be responsible for that child. So one of the things that the school nurses do is we do individual health care plans or IHPs. Now, we're looking for what are identified areas of concern between, like, what do we see and what does the child see? I also believe that the goal should be agreed upon between the child and myself. The IHP should be age appropriate. You're not going to want to say that to a first grader or a second grader that they can calculate their own carbs and then do their insulin to carb ratio. That's just not really very realistic. You're going to want them to say what is a good choice and what is not, and why is it important that I need to eat all of what's on my plate, and let the nurse know if I have something extra. And you're also going to have, it's also going to have a time frame. And I usually have it in quarterly. So in the toolbox, this is what the their individual care plan looks like. It's a lot. It's kind of daunting for me, at least. It is, but it encompasses everything. It will, you know, and again, it's got to be age appropriate because according to this, the child will accurately identify potential causes of hypoglycemia, but you're not going to be able to have a first grader, second grader. Sometimes even my sixth graders are not even going to be able to say this accurately. But again, this all can be individualized. And this one continues to go on. They will, you know, are they going to remain in their target ranges? Do they have, oh, there you go, assign an unlicensed assistive personnel. But I don't think that should be on a child's care plan. We should have a conversation with that person to make sure they do it. And then but now here, this is one that I did for my granddaughter when she was in my building. It was just short, sweet. It started when she was, I have evolved it, but when she was in sixth grade, I wanted her to know the risks for unstable blood sugars. And I wanted her to cover correctly for what she was eating. I also wanted her to be honest with what she's eating. Unfortunately, some of my kids are not always so honest about what they're eating. They figure if they don't tell me, it's something free. And then the goals and outcomes are she'll maintain a blood glucose less than 180. She will be able to verbalize the importance of an accurate blood glucose reading, not just guessing. She will verbalize the understanding of correcting for all that she eats. That was a big one for her. And then also verbalizing what good food choices were. And then, of course, the interventions. And then when I was going to evaluate these. And then she also had a knowledge deficit related to, they are bombarded with so much information that they always don't get all the information. So as a school nurse in my building, I am constantly just talking with my kids saying, what are you eating? You know, the importance of having your blood sugar in a good range. You will, like it was said, how one of the things was, how are you feeling? I have children and they'll say, I just feel funny. And I'm like, so how does this feel? Are you dizzy? Are you, because we're looking and they're not diaphoretic. They don't have the classic signs that we learned in nursing school. You know, some children feel dizzy. Some children, I had one child would feel sick to his stomach. I had, they would have headaches. They would, some children, their behavior changed. So if they were high, they would come in and I am actually referring to my granddaughter as well, that she would just be fussing at me and yelling and just not listening. And usually, and I know it said don't ask for sugar, but I would say, time out, what is your blood sugar? And she'd whip out her transmitter. It's 345. And I'm like, okay. And I know right then not to have a conversation with her because she's not going to hear me. She's not going to listen. Let's just work our way through this. And, or they'll come in crying because their blood, they're low. And why are you crying? Okay. So again, in my office, I will go, let's rule out a lot of the possibilities. Let's check your blood sugar. Let's check, you know, when did you eat last? Is anything hurting? And I can say by the time they're in 8th grade, they'll come down and say, this is how I'm feeling. And they'll look and they'll say, yes, I need to have a juice or I need to correct, which I appreciate because now when they go to high school, then they're more of an advocate for themselves. But the care plans don't have to be so intricate. They just have to meet the needs of the child. So here are these are some other additional goals that you could put on for your care plans. The impaired self-management, the readiness to improve their self-management. Are they ready to learn? Are they willing? Because sometimes it takes us 3 years to get them to the point going, oh, okay. Sometimes it takes me 3 years just to convince them that wearing their CGM all the time is really way more beneficial for them. What kind of social engagement with their peers and their family? How, you know, teaching them how to be able to go out with their peers and how to navigate, they're all eating this or they're all drinking this, and how do they how do they work that out? I can say from personal experience that children who have pumps, that works out much better because then they don't have to stop what they're doing to give themselves an injection. They can just dial it in. But again, you need that readiness for self-management, and they have to have that ability to be able to work that. Again, that comes with age appropriate. Healthcare coordination. Sometimes you do have to talk with the doctor, talk with the parent, talk with everybody to make sure that we're all on the same page. We all want our children to be successful in school. Hands down, that is the reason school nurses are in the building, so that our children can be successful, that they can navigate through school with their peers as safely and easily as possible. And then, of course, the transition planning, which I probably should have gone first, for the high school seniors, so that they do advocate for themselves. They do go talk to their college counselors and coordinators and folks like Dr. Saylor to make sure that their accommodations are in place. Whether they use them or not, let's get them all, they need all the accommodations that they can get. And then the emergency care plans, first off, you need to know the school campus plan. If you have to evacuate the building, where is it that you are going? What does that facility look like? Where is your like for nurses, where's the disaster bag? What does this child need? The other thing is, what is the disaster? Is it something that you know that the kids are all going to go home for right away? Like, there has been a time where we evacuated the building, and from the second place that we went to, we got buses and they just went. Or are we going back into the building? You want to provide this plan to all the adults who have daily contact with the child. And the emergency care plan is just not for disasters, but it's also, is the child hypoglycemic? Is he or she hyperglycemic? So that is why you would want all the adults to have that with contact with this child to have one. And you need to know to explain it to them so that they understand it. Just not that they have it, but they need to understand it and how to implement it. And then you want to include all the stakeholders in creation of this emergency care plan. So you want the parent, you want the child, you want your admin, you want the teachers, you want, maybe the cafeteria worker, maybe the bus driver, but you want everybody to do this. Now, here in Delaware, most of our children do go to Nemours, and they will give us, no, that's not this, but they will give us that emergency care plan where if the child's blood sugar is this is what you're going to correct. If the child is low, this is how many carbs you're going to give. And then you're going to when to check ketones. So they all spell it out for us. But like I said, there are some places that do not have, are not as fortunate as to have Nemours, or they may not have a school nurse in every building. So here is another emergency care plan that you can use to be given to, say, the bus driver, say the teachers, because they're not going to be giving meds, in all honesty. But you want them to know that they need to notify the school nurse immediately. They never leave the student alone. If it's possible, they can check the blood sugar. But again, my thing is, I want them to notify me if I'm not around, like if it's on the school bus, call 911 and they notify a parent. That is really what I want, because the rest of this we can do. And then advocating for students with diabetes. First and foremost, again, have a discussion with the parent. I believe that this is the most important thing that we as school nurses can do for our kids with type 1 diabetes. It is to advocate for them while they're in our schools. We need to reach out and work with the parents. We're their allies. There should not be fighting. There should not be power struggles. We are allies and we have the same goal. Our goal is to make sure that this child is safe and successful in school. We want them to be ready to go on and transition from me to high school, to college, into the workforce. We want them to be productive adults. We want them to get married and have kids and have all those fun things that they're entitled to. And I really can't stress enough to have conversations with parents. They know their child the best. They know when, just ask them what kind of behaviors are they when they're experiencing high blood sugars or low blood sugars, or just having that conversation with them. If they want you to call them, then I call them. But And even while I'm doing that, I still advocate for that child's independence. I try, well, do you want them? They're going on a really short field trip to the library, the Newcastle County Libraries. They're going to be gone an hour and a half. Does somebody really need to go with them, Mom? And, or, you know, Mom, do you want to go with them to Great Adventure, Hershey Park? But those are the kind of things that we need to work with parents about. And again, like I said before, if our parents trust us, then the kids will trust us. And with that trust, we can do amazing things. Also, again, work with, does the child need an IEP, or will the 504 best meet their needs? And then again, advocate, call everybody in, include the students in the planning process when age appropriate. You will get more buy-in when they agree upon it. I have learned that from years of experience. And let's see. And here's some resources. These all can be found on the National Association of School Nurses. It's free for anybody. You can look them up. You can look at, there's the whole toolkit, I believe is like 166 pages. There is a model for school nurse-led case management. Again, there's a whole manual for children with chronic conditions, improving care coordination for students with chronic, there's a toolkit for that. Yep, there's all kinds of stuff on that website. And there you go. I know I'm fast. It's been a long day. If you have any, what kind of questions do you have? Here's my contact information. I'm much better with questions personally.
I didn't unmute. I do have, looks like quite a few have popped into the Q&A, and there's a couple in the chat as well. So let me note here. The first one, iPads or mobile phones for C monitoring. Is it the parent's responsibility or the schools/district's responsible to provide the school nurse with a device for blood sugar monitoring for students?
No, the schools will provide the school nurse with an iPad, but the child, and it will connect to the child's CGM. So when the child leaves, then the iPad stays in the nurse's office. So the iPad, or it's an iPad or it's a phone, either one, that I know for in my district in Red Clay, they provide that technology to the school nurse for that constant monitoring if that's what's needed. Did that answer your question?
Okay, if it didn't answer the question, you can type into the chat or into the Q&A again. So a couple of questions that popped up, I will share out. So I keep seeing, will we be sent the slides? So they'll be posted on the website with the recordings. So you will have access to these slides. Another question for you, Sharon. How are schools handling seeing blood glucose readings with the Libra devices? Are schools providing phones for nurses? I think you might have answered this with the last one. iPads are not compatible with the Libra technology, or are they still just coming down for checks as would do prior to this kind of monitoring?
So in my experience, I've had one child with a Libra device, and he would just come down, check his blood sugar, let me know. And he was also looking at his carbs for lunch. In my case, I didn't have an iPad, or I didn't have anything to connect, because he never ate lunch with me and his blood sugar was fine. Like he's a weird, his is a weird case, but for him, he just came down, checked it, and he left. And in my building, what I have is the children do come down at lunchtime. They just let me know what their blood sugar is. One child comes down because he also takes this Lantus in the afternoon, and we have to figure out, he drops low. So we have to kind of figure out, is he going to cover or is he not? And then another child also will come down, and she looks at the menu. We have an online menu that does carbs. So she checks that out. So I get to, they just come down to me at lunch.
Great, thank you. And I have another question here. Oh, and more coming in.
Good.
So
Good.
that this is from an anonymous attendee. The toolkit has great tools to help identify whether or not a student can self-manage.
Yep.
Are you aware of any districts in the state that have guidelines in place?
No, I think I'm not aware that we have guidelines in place. We use NASTN, the NASTN toolkit, or we just use the NASTN toolkit as far as I know. Like we also go by, if there are the other guidelines we use are what comes from the MORS, from the doctors.
Sense. Great, thank you. And I have similar question, 2 places here. And it kind of ties in with what you were with the last question. So is the 504 plan that you referenced earlier on the NASN website? If not, could you share it with us?
It is the one that it was on in the PowerPoint is on the NASN website. The second, that one is on there. Each district has a little different 504 format, I'm thinking. So the format for our 504s in Red Clay are a little bit different than that one, but you can use the same goals. You can use the same format when you go in to talk and advocate. You can say, all right, this is what we need. This is what we need. This is what we need. The format may be a little different depending on the district, but you can put the same information into whatever form is needed, is used.
Great, thank you. And I think I have answered all of the, or asked all of the questions that are currently out there. Is there any more questions that anybody has either in the Q&A or in the chat? Oh, I think I see one popping in. Oh, a comment. So in my school district, the counselor does our 504s.
And the counselors do our 504s as well. However, I am invited to those meetings. I have, in fact, I have initiated some of those meetings. I have gone to the counselor and say, hey, we have a child, they're going to need a 504, especially when I know if they don't have one and state testing's coming up and they're using their phones for their CMG readings. So yes, guidance counselors do the 504s, but we as nurses need to invite ourselves to go into those meetings and hand them, say, this is what the child needs. Again, that goes back to advocating for the kids.
Wonderful, thank you. And it does look like this this individual added that they do have the nurse there for input as well. So great.
Perfect.
Wonderful. And any other questions or comments from any of the participants? Oh, a couple more coming in the chat. So it's a suggestion for anyone who is aware that their kids are missing their basal dose at home is to have them do it during the school day. So a nice comment.
Yes. Like I said, one of my children, they use that they did Lantus at like 12:30. That seems to be working for him.
Interesting. And it looks like someone has added that IHB Creator is a great online program for school nurses. It does have to be purchased though.
Yeah,
Great. Well, I'm noticing, I think that our comments and questions have kind of cooled down now. Thank you so much for your time and for your great presentation of this toolkit. I have learned a lot tonight. And I will say a common kind of thread that I noticed throughout was really talking about that communication piece, communicating with the kids, communicating with the youth going into college. So I thought that was a really great thing that jumped out at me. So thank you both so much for your time tonight.
oh, thank you. And like I said, for me, I enjoyed Dr. Saylor. Like, I love that letting go, let them be. That is perfect.
Oh, your presentation was amazing. I learned so much. I was sitting here taking notes.
Oh.
Because when they come to me, I could be like, well, when you're in high school. So thank you. That was very helpful. And again, Kimmy and Sarah, you guys were amazing. Anything I can do, and I'm sure Sharon Rose would say the same thing. I need you to help the coalition. We're here.
Absolutely. And if you have any questions, please reach out.
Yeah. Thank you to everybody who stayed with us, right? I mean, it's late. You guys have
Yes.
to get up and go do it all over again.
Yes. Thank you for those who listened.
Yeah, thank you so much, and glad to hear that you're welcome, you're interested in taking questions and working with the Diabetes Coalition. I'm going to share one more screen for everybody with the evaluation. Again, that we have asked to have that done by February 28th for you to be able to get your CEUs for attending this evening. And so we saw how the screen sharing was going. It can be a little tricky, so bear with me a moment. Are we seeing the learning outcomes on the screen?
Yes.
Okay, and now I should be able, let's see. Here we go again. There we go. So the form should be up. Let me see if that is what I have saved in my chat here. Nope. I will throw it into the chat as well. And if you could take a moment to fill this out, or if you can't write this moment, again, just by February 28th. It's not letting me do this. It's in the chat now, and I'll reshare that screen. See everybody, thank you so much. And I've seen quite a few thank yous come into our presenters as well. I'm going to hang on a little bit just to let everybody get that evaluation link, but everybody enjoy the rest of your evening. Thank you so much for hanging in tonight.